Aortic valve stenosis develops due to age-related calcification, congenital abnormalities, or rheumatic heart disease. Narrowing of the valve increases the workload on the heart, leads to left ventricular hypertrophy, causes dyspnea, chest pain, dizziness, and raises the risk of life-threatening complications. Once symptoms appear, surgical aortic valve replacement becomes necessary. In this video, we will demonstrate step-by-step aortic valve replacement using the Ozaki procedure. Modern cardiac surgery employs various approaches, including minimally invasive options, thoracotomy, mini-sternotomy, but in many cases optimal access to the heart is achieved through a conventional median sternotomy, a vertical incision through the sternum. The pericardium is dissected from the surrounding tissues. When harvesting its fragment, it is important to consider the course of the phrenic nerves and the position of the diaphragm to avoid injury. In addition, caution is required due to the close proximity of the beating heart. The harvested pericardial patch is placed on a special board. There, it is carefully secured and evenly stretched to create a smooth, fold-free surface, then gently cleaned of excess adipose and connective tissue. The fixed and clean pericardium is placed in a glutaraldehyde solution for 8 to 10 minutes and then rinsed 3 times in normal saline for 10 minutes each. Cardiopulmonary bypass is required during the surgery, temporarily replacing the function of the heart and lungs. The surgeon places purse-string sutures on the aortic wall, carefully avoiding perforation on the right atrium and for the cardioplegic cannula. Oxygenated blood is delivered to the body through the arterial cannula, while venous blood is drained through the venous cannula into the pump, where it is re-oxygenated. After cross-clamping the ascending aorta, a specialized cardioplegic solution is administered to induce controlled cardiac arrest. With the ascending aorta opened, the surgeon visualizes and excises the affected valve. During this step, the valve is removed and the aortic root is carefully cleaned from tissue fragments and calcium deposits to prevent debris from entering the left ventricle or coronary ostia. Next, the bases of the sinuses are measured and their midpoints are marked. If one of the sinuses is significantly smaller than the others, aortic root grafting is indicated. The surgeon makes a longitudinal incision in the aortic wall along the smaller sinus, extending down to the fibrous annulus. The patch is sutured to the base of the sinus, and the suture line is then continued upward along the aortic incision. The upper edge of the patch is secured at the level of the sinotubular junction. Once the repair is complete, the measurements are repeated. The enlarged sinus is now comparable in size to the other two. After glutaraldehyde fixation and triple rinsing in normal saline, the pericardium is extracted. Using a dedicated template, the outlines of the cusps are drawn on the pericardium and the necessary guiding marks are made. The 3 cusps are then cut out along these marks. The surgeon aligns the pericardial cusp according to the marks and places the first anchoring suture at the center of the sinus base. Subsequent sutures are then placed one by one on both sides, advancing toward the commissures and observing the 1 to 3 rule of needle bites, which ensures even distribution of cusp tissue and formation of its proper dome-shaped profile. In the commissural areas, several sutures are deliberately brought out on the external surface of the aortic wall. Tying them on the outside secures the commissures at the desired height and brings the coaptation points together. After both commissures have been fixed, the cusp assumes its final shape. The same suturing technique is repeated for the remaining 2 sinuses, creating a reconstructed valve with symmetric new cusps and a central coaptation line. The Ozaki procedure restores physiological blood flow through the aortic valve. This markedly relieves symptoms such as dyspnea, rapid fatigue, and other manifestations of heart failure. The use of autologous pericardium generally eliminates the need for lifelong anticoagulation and reduces the risk of thromboembolic events and bleeding, further improving the patient's quality of life and long-term prognosis.